Hello and welcome to the third of our audio casts, this one entitled Patient Into Incision, Recapturing Hidden Lost Time. My name is Tim Sweeten. I am a Senior Managing Director for the Perioperative Consulting Services here at Accelero Health Partners. With me today is Director Matt Nicholas. He's a Lean Six Sigma Black Belt. Matt is responsible for assessments and implementing our perioperative projects throughout the United States and abroad. So Matt, let's get right into it. Can you describe for us what patient into incision is and why do you consider it so important?
Absolutely, Tim. When we refer to into incision, we are simply referring to the time from when the patient arrives in the OR until the surgeon performs the incision. This time can also be thought of as the patient prep time in the OR versus the holding area or same-day surgery area. We generally find that when we are working with hospitals, they tend to lump this time period into the overall procedure or case time. Once going down the path of breaking out the metrics separately, it is often interesting to see the variation in duration, even when looking at times from the same surgeon and the same procedure. In that variability tends to lie our opportunity to capture lost minutes.
You know, I could not agree with you more, Matt. I know my experience has been that the staff and physicians seem to be so focused on getting the patient into the room on time because that is what is important to them, getting the patient in. And then after that, everyone can sometimes take a breath, and at that point maybe aren't as focused as they are on the next steps between patient into when the knife falls and incision happens. So help us understand, why does into incision matter?
That's a great question. Too many times when we go down the path of talking about the change process, individuals end up losing the sight of the original goal. So let's take a step back and talk about the benefits of improving the efficiency of this metric into incision. There is both an economic benefit as well as a possibility for benefits to capacity overall. Let's start out by assuming that on average 4 cases are currently being performed in an OR on any given surgical day. Let's also assume that the variability in practice has identified an average of, let's say, 10 minutes of lost time during the into incision time period per case. If we assume an average of $60 per minute, the result at the end of the day would be the opportunity of approximately $2,400 in operational expense. That same 10 minutes aggregated over the course of the day would equate to 40 minutes. That 40 minutes could potentially equate to an additional case being performed without increasing current expense.
So, wow, that it really is pretty significant and important to look at that. And that's why we're talking about how the into incision is the untapped potential or the hidden lost time that you really want to be able to identify and bring out. So what can be done? We've got some experience and some successes in working with different hospitals on identifying this metric and making improvements to the specific metric. So really our process is to identify the stakeholders who are responsible for the into incision, and I think about the people like surgeons, anesthesia, staff, OR management, everybody who has something to do with the real work of what happens to the patient during this period of time. We also think it's important to identify what metrics and how those metrics are going to be managed at that point so that we can really understand what the true minutes are for into incision. Afterwards, we work through our 5-step process. Our 5-step process being look at the metrics, bring everyone together, videotape the process of into incision, then sit people down and have people watch the videotape to be able to identify where the opportunity is, where that lost time happens, and things that are happening in parallel versus things that are happening in sequence. And basically this team gets together and then identifies what those the new processes should be, come up with a standard work and parallel processes. So that at a glance is really what we think can be done to improve that. So let me give you just an idea of how we've made this work in the real world. We were working with a hospital in Milwaukee, and this was an area of opportunity that we really saw that was untapped. So first we looked at the metrics. We identified that their metrics were about 10 minutes over what we thought it should have been. It was about 38 minutes for the into incision. And after we took the time to videotape the process and show that videotape to the people, some things stood out to us. One of the big things that stood out to us was the fact that they were doing the spinal in the room. So anesthesia was getting the patient in, positioning the patient, putting them on their sitting up, administering the spinal, then laying them down. All of this happened in sequence while everybody around the patient was really stopped and waiting at this point. And we saw this easily added an additional 10 minutes per procedure. So what we did was we got anesthesia surgeons in the group together, as I said before, and we talked about what needed to happen to allow for that spinal to be done in the pre-op area. Now, initially, anesthesia was resistant to this idea, and with good reason. They really wanted to make sure they could do this in a safe way. So they needed monitoring equipment. They needed everything that was necessary to have this done in the pre-op area. After OR administration agreed and found some of that monitoring equipment, anesthesia was able to make that change and do that anesthesia, do that spinal in the pre-op area, and then wheel the patient down to the OR. Through this way, and standardizing this component of the into incision, they were really able to realize that 10 minutes savings for each and every case that they were doing that. These were mostly total joint replacements. So that's one way that we would encourage everyone to follow the same process to identify where their opportunities might lie in this area.
That's a very powerful message that and overall change that came through that specific work that you had performed with the hospital, Tim. I'm sure you can agree that it was very important to have all the different stakeholders involved in that process change. So I think that it's important to really think about the overall impact of everything that we're talking about. So in summary, we all know that as the culture or the environment within healthcare continues to change, as reimbursements continue to decline, hospital administrators are going to be asked to do more and more with less and less resources. And it's very important, it's really imperative for administrators to have these tools, the tools that we're talking about now, and the tools being understanding the metrics, looking at the different processes, breaking them down, to start to change the way that they manage. It's imperative to make these changes to be able to adapt to what senior leadership will continue to ask of them to ensure that levels of frustration do not come into play and that they can continue to provide such a high level of care with these continued increases in expectations.
Absolutely correct. So, on behalf of Matt Nicholas and myself, I'd like to thank you all for joining us today. If you have any other questions or would like to discuss your perioperative services situation that you're currently in, please reach out to your local Zimmer representative. They will be happy to set up a conversation with you and Matt or myself. The other way to reach us or to learn more about us is to visit our website, and that is www.accelerohealth.com. Thank you.